Hello, everyone. My name is Barbara Goodman, and I'm the President and CEO of Cures Within Reach. Welcome to today's webinar on engaging social services and faith-based organizations in clinical trials. Before we get started, if you have not yet participated in the initial welcome polling, we encourage all of you on the right side of your screen to click on the welcome poll button. There are 3 quick questions that the panelists and the moderator and the Cures team would love to know who is attending with us today. It'll help us make the conversation as focused on your goals as possible. We're very excited to have this session today. Real quick, couple minutes on Cures Within Reach. We're a Chicago-based nonprofit that is focused exclusively on finding and funding clinical trials that are testing already approved drugs, devices, diagnostics for diseases that have no current treatments, focused on new treatments that are fast-track for patients. We're disease agnostic, we're geography agnostic, and we are institution agnostic, funding clinical trials all over the United States as well as around the world. We focus specifically on building the clinical evidence for a regulatory approval path or for off-label use by clinicians based everywhere, known as off-label use. We are 20 years old as a nonprofit this month. We're very excited to be celebrating our 20th year. This is a little bit about our earliest success. We funded Mayo Clinic and thalidomide, which became a wonderful treatment for multiple myeloma, and then spun off alternate analog treatments using very similar approach that are all still in use today. And our most recent success story is in acute myeloid leukemia, led by University of Pittsburgh, and some really exciting research that led to over $3 million from the FDA to fund the larger trial that is ongoing now. Great examples of the success and the history of Cures Within Reach. How do we measure our success? We focus on the catalytic funding that our PIs are able to receive that will help fund the further larger phase 2B, phase 3 clinical trials. In calendar year 2024, those researchers and the clinical trials we helped to fund raised $29 million in follow-on funding. Incredible number, and we're really excited about that milestone. Currently, we have a portfolio of funded trials, as I said, all over the United States and the world, over 50 ongoing trials in a wide variety of diseases for both adults and pediatric patients, and also mostly drugs, but certainly we also fund medical devices, nutraceuticals, and other areas as well. Just to give you a real quick highlight, our clinical trials in rare diseases are in a number of different areas as described here. Sickle cell disease in rare diseases called HLH, not only in 10 different states around the United States, but also in Bangladesh, Tanzania, Nigeria, and in Vietnam as well. On the oncology side, we have 7 ongoing trials in blood cancer. We have trials all over the United States, as well as trials in Nigeria and Tanzania. And the neurology side, we do a lot in PTSD, traumatic brain injury, depression, and other areas, as well as neurodegenerative diseases and chronic pains. Again, clinical trials across the United States and in several countries in Africa as well. And finally, our other area of focus is in pediatric space, and we have similarly a wide variety of clinical trials in many different diseases in many different geographies. With that, I'm going to hand it over to Claire Thibodeau, who's going to tell all of you a little bit more about when and how we fund.
Great, thanks, Barbara. As Barbara was mentioning, one of our key metrics is how much money our researchers are able to raise for follow-on trials. And that's because our funding comes at a key moment in the development of these repurposed therapies. We typically fund phase 1, phase 2A trials, which can be very catalytic, de-risking these opportunities for follow-on funding from other organizations, or even, as Barbara mentioned, off-label use by clinicians and patients. So since 2021, Cures Within Reach has started to fund community-based organization engagement, or CBOE, alongside our clinical trials, thanks in part to our lead CBOE funder, the Boroughs Welcome Fund. This has been a really great opportunity. We started with our US health disparities trial, and this effort has now grown globally, including our low and lower middle income country trials. So it's important to distinguish that when we're talking about CBOE, this is different than patient engagement. Patient engagement and working with patient organizations is certainly a very important part of clinical trials. But what we're trying to do with this effort is to work with community-based organizations that work to support these communities in a more broad and overall way. These are organizations that are trusted by the community, that have been working with the community for years, and are a great entry point for for researchers who are interested in starting CBOE. There's a number of different types of these organizations, but the organizations that we're going to be focusing on today with our discussion include social services and faith-based organizations. So if we move to the next slide. These social services organizations can run the gamut from YMCAs, from food banks, and even barbershops. These are organizations that may not have a focus in healthcare, but are certainly involved in supporting the community. And then we have faith-based organizations. Faith-based organizations are the center of many types of communities, but especially when working with underrepresented communities, it's a great place for researchers to plug in and make that connection. And I just want to be clear that when we're talking about underrepresented communities, these can include rural populations, low-income populations, people with disabilities, racial ethnic minorities. So there really is a wide variety of different underrepresented communities that these organizations can indeed connect with. There's also another type of CBOE, which we're not talking about at this time. These are community health organizations, also very important to the overall community engagement strategy. However, last year we had a webinar just like this on that topic alone. So if you missed it or you want to watch it again, you can find that video on our website. So again, I just want to give a thank you to our philanthropic and industry partners who are supporting community engagement, not only alongside our trials, but also webinar and educational events such as this one that we have for you today. And we really do have a great agenda for you today. We have speakers from philanthropy, clinical medicine, and of course, social service and faith-based organizations. Each of our panelists are going to introduce themselves to you in a little bit, so I'm not going to focus on that right now. But I do want to remind you that on the agenda, you can see after the panel discussion, we will be having time for audience question and answer. So if you want to ask a question, please use the Ask a Question button on the webinar platform. At any point during the conversation, feel free to type your question in, and we will share it during the Q&A session. So with that, I'd just like to now introduce our moderator, Tammy Collins from the Boroughs Welcome Fund. We're so excited to have her with us again this year. Tammy's going to start with a brief introduction and then take us into the panel discussion. Tammy?
Yeah, thank you so much. I'm so glad to be part of what you're doing here today. So I thought I would just give a brief introduction to the Boroughs Welcome Fund before we open it up to questions. For those of you who may not be as familiar with us, once upon a time, there was a pharmaceutical company called Boroughs Welcome that established a nonprofit arm of the company all the way back in the 50s. In the 90s, we were gifted $400 million from the Wellcome Trust. This is an organization based in the UK who we are most often confused with. And they gave us this gift to allow us to break off and be a completely independent, nonprofit private foundation, separate from any pharmaceutical companies, separate from any other organizations. Today, our endowment is around $800 million, and we award close to $40 million per year in grants to institutions specifically based in the United States and Canada, although we do support international collaboration through our efforts. Our mission is to serve and strengthen society by nurturing a diverse group of leaders in the biomedical sciences, specifically with the goal of improving human health by supporting education initiatives, as well as powering research discoveries in some of the frontiers of greatest need. In some of those areas that the NIH and other larger funding agencies may not be putting as much resources in, but are still very important to pursue. That's where philanthropy can come in and fill in those gaps. So we largely accomplish our mission through two main ways: competitive funding mechanisms, as well as what we term ad hoc funding. And that's actually partially, how we fund the community-based organization engagement initiative with Cures Within Reach as an example. So our particular focus areas are shown here, and I won't have a chance to go through all of those, but this is just to give you a sense of the wide array of program areas that Burroughs Wellcome Fund focuses on. One of the ones that I'm going to highlight briefly has to do with regulatory science, because that's most closely related to the work that we're talking about here. So the Innovation in Regulatory Science program is an initiative that runs every other year. So this program will have a call for applications next fall. And you can look at the QR code here if you want to sign up and get on a listserv to be notified of our RFP. So this was created a little bit more than a decade ago to encourage innovation in developing new tools, standards, methods, or approaches to better help the regulatory agencies such as FDA and other regulatory bodies assess the safety and efficacy of therapeutics and devices. This provides $500,000 over 5 years, with one of the goals being to foster academic regulatory science career pathways. For the past couple of years, we have specifically emphasized advancing equitable outcomes, and that has become part of the rubric in evaluating applications. We're also looking for those that incorporate patient input into the drug development process as well. Just to give you an example of one of the things that we funded a couple of years ago, and this particular project was advancing regulatory science to assure that clinical outcome assessments were reflecting diverse patient experiences. In this particular work, one of the PIs has developed a patients program where individuals are integrated within the research teams. They also partnered specifically with churches, and one of the key pastors in the Baltimore region is part of their research team as well, and actually attends all of their meetings. And individuals are compensated for their time that participate in this. So the other mechanism I mentioned in terms of accomplishing our mission was through ad hoc funding. So some of the examples I mentioned, our support of community engagement through Cures Within Reach. We are supporting community ambassadors for the Voices of Black Women study through the American Cancer Society. We are also building out a broader, larger initiative centered around digital health technologies. And our goal is to actually support the communities first, to find out what are some of the problems that they most need help with, and then pair them with researchers so that the community voice is not held off until the end, but it's centered at the very beginning and integrated into all of the work. And that's something that we're actively developing now. So finally, I wanted to acknowledge my team, especially Eliza Gary and Lima Hadar, as well as our communications team. And last but not least, our president and CEO, Lou Muglia, for supporting our efforts. And with that, we'll get into our conversation today. So our goals are to learn what social services and faith-based organizations wish that PIs and clinical teams at research institutions knew. It's also to discuss how to engage social services and faith-based organizations successfully in order to achieve win-win scenarios for both researchers as well as the organizations. And finally, to share opportunities and challenges for social services and faith-based organizational engagement. We will open it up to each panelist, and would like to ask you all to share more information about your organization and role, and then a short summary of your own perspective or experience in engaging social services and faith-based organizations in clinical trials. So to kick it off, I will call on Dr. Natalie Razine.
So, hello, everyone. Thanks so much for having me. So I'm a genitourinary medical oncologist. I predominantly take care of patients with advanced prostate cancer, and I'm at University of Illinois Health Cancer Center. I was very fortunate to be funded through Cures Within Reach for a window of opportunity trial evaluating glycyrrhizin, which is an active component in licorice root, in between, the very important time when a man's diagnosed with localized prostate cancer and then is about to go to prostatectomy. So it's a clinical as well as a translational trial with a number of different correlatives. In terms of community engagement, I was completely, brand new to it prior to starting as a clinician investigator at UIC. We have a really wonderful community engagement, health equity outreach office that was able to really supply me with the connections that I needed to get started. And now I will say that community engagement goes beyond my Cures Within Reach grant and is really something that I enjoy most about what I do as a clinical researcher. And I'm happy to talk more about that.
Thank you for sharing that. Next, could we have Pastor Cy Fields?
Yes, hello. Good afternoon, everyone. So glad to be here. My name is Pastor Cy Fields, and I serve at the New Landmark Missionary Baptist Church here on the great west side of Chicago, Illinois. And I'm representing and part of the Alive Faith Network, which is with Rush Hospital here in Chicago on the west side. And the Alive Faith Network, our approach is that we combine the unique community and academic relationship. We blend wisdom and faith with Rush's scientific knowledge, and all that is designed to improve holistic health within the African American community, starting with the African American clergy. The Alive Faith Network, at the core of our mission, we want to work to close the in excess of 10-year life expectancy gap that exists between African Americans and their counterparts. And so that is sort of a driving engine, if you will, for us, as well as addressing many of the health disparities that we see within the African American community and our community and cultural counterparts. And we have had over the years, over the past 10 years or so, a measure of success of working and blending that sort of research and health program, health initiative with the faith community through the Alive Faith Network, through various programs, and whereby we've been able to, starting off in its pilot form, just having 5 to 7 churches that were focused, that now we have in programmatic focus over 30 some churches with an extended reach of hundreds of other churches in the Chicagoland area that we have a thumbprint on, that we can engage in research efforts, health initiatives, and programs that come through Rush and the Alive Faith Network. And so with that, we've had some things and some practices that we found to be successful for us here in Chicago. Primarily, the Live Faith Network has worked on the south side, but I'm on the west side, excuse me, but we do have south and west side reach in terms of working with other faith community and churches throughout the city of Chicago. And so I just look forward to sort of sharing those kind of things and best practices that we found to be successful, that hopefully that those of you who are involved in clinical trials and things of that nature will find helpful in your future endeavor.
Thank you so much, Pastor Fields, for sharing that. Next, Dr. Paris Thomas.
Good afternoon, everyone. My name is Paris Thomas, and I am the CEO of Equal Hope. Equal Hope was formerly called the Metropolitan Chicago Breast Cancer Task Force. We are a 501c3 located in the Chicagoland area that was created specifically to address the disparity in Black women's breast cancer deaths. In the city of Chicago, Black women were 62% more likely to die from breast cancer, was greater than any other city in the nation. And so we created a task force of individuals, our academic institutions, our safety net hospitals, community partners. Over 200 entities came together to form our organization. And we have a model where it is a three-pronged approach. We have our Equal Care, which is our research arm. It allows us to partner with academic institutions and leverage our community-based knowledge to really further a lot of their research. Some of our main partners include Rush University as well as UIC in a lot of those projects. We also have direct services, which is called Equal Access, where we do outreach, education, and patient navigation to specifically be able to provide this. We find many times in research that our community health workers are a tool that is utilized in many research projects that want to do that community-based participatory research, because they understand the communities and they're going in places where most people wouldn't go, looking for the constituency that people need for research. And then we do policy and advocacy work. Our organization has been credited with lowering that death rate in Black women's breast cancer deaths to 32% in 2018. And so our model has expanded to address other inequities in cancer care, as well as ensuring that individuals have access to care as a whole.
Thank you for that. Great to hear that improvement, by the way, too. Also, next we have Courtney Christian.
Hi, good evening. My name is Courtney Christian. I'm a Deputy Vice President at PhRMA, which is the trade association that represents many of the world's leading biopharmaceutical companies. Our companies spend millions to invest in research and development, driving innovative medicines every day, but we recognize that that innovation doesn't mean anything if it can't get to the patient. And it also doesn't mean anything if we don't have representative trials to understand where the patient need is and to make sure that the medicine has efficacy for all the patients that it's intended for. And so my work here at PhRMA really focuses on that. How do we expand clinical research? How do we broaden access to medicines within public health programs? And also I work on shaping global frameworks on equitable health practices. From an industry perspective, a few years ago, we thought about how we could be better in expanding clinical trial access and reach. And one of the ways that we decided to do this was to fund a learning phase, a project called Equitable Breakthroughs in Medicine Development. And what we were seeking to do there was to really change the paradigm of how industry approaches clinical trials, whether we just kind of go into an area and set up shop and leave. We thought, what would happen if we went into a community and stayed? If we put down roots in a familiar place where the patients know where they're going, if we made inroads with providers, and if we made sure that clinical trial sites have staff that looks like the community, PIs, investigators, researchers. How do we make patients understand within certain communities that we're here to help and not to harm? And so that is one of the big ways in which industry has invested in trying to reach into communities, forming community ambassadors, working with faith-based organizations and other social organizations to make sure that we really reach patients right where they are at their time of need.
Thanks so much. And last but not least, Dr. Eddie Amorim.
Hey everybody, thank you for the opportunity to join you today. I have a lot to learn, that's for sure. I'm a neurologist. I work at the San Francisco General Hospital, and I'm part of the University of California, San Francisco. I work in the intensive care unit. So the patients I care for is a very different type of approach in terms of enrolling patients on clinical trials and how we reach to patients. Most people are not planning to have a neurological emergency, right? So it's different from someone that has a diagnosis that's going to be followed long term. So we do have to engage with the community very broadly to access patients and make sure that their needs and their goals are met when we are planning studies as well. So we're working with the Curious Within Reach for 2 years or so, and now they supported one of our studies, which is focused on patients who have cardiac arrest. Their heart stopped to get resuscitated, and people will make it to the hospital and to the ICU where we are caring for them, and then they would potentially participate on the study. So our approach has involved reaching out to people at risk for a cardiac arrest, and one of the main things that we see in San Francisco is the overdose crisis and the increase in overdose as a main driver of cardiac arrest in our town. So we have then engaged with faith-based communities, social services, and many different groups that participate in engaging those patients, not necessarily for cardiac arrest, right? They're engaging for other reasons, but we are trying to find places where we can contribute to the education on that risk that many people actually do not know about. So I think it would be interesting to hear from the other speakers and share some of that experience with you as well today.
All right, thank you so much. I also wanted to give a quick reminder to all of the attendees that you can submit questions in the platform, and we will answer those at the end. So we're breaking this up into the why and the how. So the first part of the conversation is going to center around the why, and we want to get thoughts from Dr. Paris Thomas and Pastor Cy Fields about why individuals should work with social services and faith-based organizations, some of your thoughts about how those collaborations can strengthen clinical research, and what does it mean to include organizations such as yours throughout the trial journey and not just transactionally, but as long-term partners. So I see Pastor Fields is unmuted, so if you'd like to go first, and then we'll hand it off to Dr. Thomas.
Well, if I knew that had me go first, I would have paused. Yeah, what a great question. The question of why, is always important because, many times as clinicians come to the table with the what, and it's the why is a good piece, right? Why should researchers, clinicians work with faith-based organizations or the church? One, I think the very number one reason is a trusted voice. It's a trusted voice within the community that has been, in most cases, a long-standing trusted voice in the community. When it comes to the African American community, as many of you are aware, that there is not without some hiccups and some potholes due to the history of bad research, things that have happened, such as the Tuskegee syphilis study, things of that nature that has fostered a measure of mistrust over the years, and to some degree, still, some of that still may linger on as well. And in some cases, the word research can be very intimidating for those in the African community or within the faith community in general. But the why you should work with faith communities is because, again, it's a long-standing institution. And one recent experience that we've all experienced during the COVID pandemic was that because of the faith community and the church is a trusted voice and a trusted institution, it was able to be a vehicle and an instrument of providing information, tests, serving as vaccination sites, points of information, etc., when so much was uncertain about the COVID-19 virus. And so that's just one example. And I think the other part regarding how do you not make it transactional, because sometimes, at least from my seat, and I have the advantage of being a pastor, which with the Live Faith Network, being a participant in the early pilot phases, and even to the point now, of course, I work with the Alive Faith Network team at Rush Hospital. So, and I'm able to see it from both sides of what the needs are in my perspective as a pastor, but also trying to advance what the team is doing in terms of its health initiatives and research and things of that nature. And so how to not make it transactional is really a measure of being engaging, if I could use that term or phrase, right? It's how to build a relationship, right? Where there's continual conversation. And maybe it's in between, for example, site visits, if I may use that term, right? What happens in between the actual research transaction, if you will, right? And so it's having that relationship, having that communication with the church leaders and the congregational members or participants is paramount. Also, it's good to understand and know, if I may say, to know their values, know their mission, right? It is a trusted institution, and what makes it non-transactional is that there's a synergy or measure of agreement in terms of mission and purpose that hopefully you can align with. I happen to understand the importance of health as well as spirituality and how the two can walk parallel one to another, right? To achieve the goal. We have similar goals, right? And so I think emphasizing that similarity of goal and mission that you have as a clinician as it relates to health and things of that nature, improving health disparities, things of that nature, that's a starting point. And so when we're able to have that conversation and share, that helps build that relationship and build that trust and have better cooperation because there's a likeness in that regard, similarity of purpose and mission that we share. So, and maintain contact. Keep it human, right? If you don't want it to be transactional, keep it human. That means conversation, even with materials, right? And I don't want to get too far away from the question, but if it involves materials, the language, make sure there's language barriers, right? How can your material be reflective of that faith community or that church in a way they see similar language, right? And so it's really how much you're willing to engage and become like, if you will, that faith community in terms of their mission and values. And then you may increase your probability of having cooperation and participation in your clinical research or your trial.
Yeah, thank you so much for sharing that. And Dr. Thomas?
Yeah, Pastor Sai basically hit it on the head, but just to add some different points from the social sector, not only is it just that trusted messenger piece, but that ability to reach. Many times when we're talking about clinical or medical research, we're looking at vulnerable populations, and it is our ability to connect with them. And when you have studies, I find it too often, many researchers come to me, I have a study, but no one that I'm looking for has signed up. And it is our ability to really find and really use sectors like Equal Hope, where we have our community health workers that are literally going everywhere where people are in their lived settings, whether it's a liquor store, it's a beauty supply store, the grocery store. They're finding people in these everyday settings to really understand and connect with them, but then also connect them to care as well as clinical research. I think when you talk about the transactional or making this partnership beyond transactional, it really is about leveraging the expertise of the social sector or faith-based organization as well to strengthen your research. So I tell people it's not about bringing us in on step 10. Why can't we start at step 1 with you? That design of that study, how it works when you talk about recruiting. Too often, many people try to bring our organization into step 10, and then I give it to my navigators who are like, I don't even know what this says. I can't help you find anyone because I don't even, how was this written? So I think starting us with step 1 to really understand how can we really embed and integrate and have the perspective of the community at the table at the first thought process, not at the end when you truly need us, because that does seem transactional. I think it's the same way when you're actually researching constituents, your ability to conduct research and then still follow up. Many times in our communities, this is a common thread and it's said often, many people want to do research on us, but they never follow up. They come in, they get their data and they leave. How do you continue to build those relationships specifically with those entities and not just through your research, but what they need? So you may have an expertise, like they would want to do other studies. They want to do a randomized controlled trial to show that their program is evidence-based. What expertise can you bring to the table to help them strengthen their realm as well? And I think we're looking for that two-way partnership in order to move away from it being so transactional.
If I can add thank you, Doctor. And that's really good. And finding that peace. Oftentimes, one thing as a pastor, we're used to, right? We're used to many people coming and wanting something from us. And that's okay. That's what we signed up for. That's what we exist, right? We're there to serve and to give, right? But as it relates to the area of health and research and things of that nature, as she mentioned, many churches have formal or informal health type ministries, right? I'll use my church. I happen to pastor the church that I grew up in, and we've always had a nurses board, right? And they dressed up in nurses uniform. Now I don't know who was credentialed or not. I don't know, but we had a nurses board, right? So that's sort of this informal organization, right? They also had a junior nurses board with short training young ladies, and others have full-blown health ministries. So how some of you can come along and help it not be so transactional, maybe answering the question, okay, this is how we can help you, right? Maybe we can help you develop or expand or flourish or enhance your informal or formal health ministry that you have in the church. In other words, what are you bringing as well? In other words, so it becomes a mutual relationship and not just a stoic transaction where, the church or the faith community is giving you what they have and therefore receive nothing in return. You have the data, you have the research and things of that nature to go on to, to other clinical things. And then, the faith community of the church is sort of just there. So when you have that idea of this is how we can help you, right? I know for me as a pastor and many others in the faith community, that's where you can establish a relationship, right? That even can possibly go beyond just your time frame of your clinical research.
Oh, thank you so much for both of your insights on this. And I think, one of the other questions we have is, could you share some additional examples of other types of social services and faith-based organizations? I know you've both alluded to those, but we think some of the researchers might have questions about what differentiates this from community health organizations. And if you had any ideas about discussing, the range of both, even if there are niche type organizations, if you have any insight into that in terms of helping individuals know where they could look.
Yeah, so I think when you're talking about community-based organizations, those are amazing. I love our community-based organizations that we have here in Chicago, but they also have a limited scope. They're limited on funding, they're limited on their ability to reach. They do reach a vulnerable population, but that's the population that has happened to walk through their door. I find often that the vulnerable population that you're probably most looking for your study, they don't have regular care. So those community-based organizations, they probably aren't seeking care there. They're using the emergency room because we study that a lot. They're seeking care elsewhere. They may not even be going to care. They may be disconnected because they just have those social drivers that stand in their way. Life is happening. I have a job that's demanding. I'm not insured. Like, that's not a primary thing that I'm focused on. And so I think when you talk about social sector, and I'll let Pastor Sai speak to the faith-based, but social sector organizations, we, on the other hand, are really reaching people who are disconnected from a lot of those systems. They don't have regular care. They're not going to be found in your community-based organization. They are truly the most marginalized and vulnerable populations who do not have the same access. And so when you're looking for that probably needle in a haystack, we're probably more likely to go out and find them. And we also have the trust versus the community-based entity or healthcare entity. They're still sitting behind walls. We're in the community, and that's the difference. We're out there finding people. We're not waiting for them to come to us.
Yeah, I can add. I think, and thank you, Doctor, for sharing. I think what the faith community, what the church can offer is that those same marginalized or disconnected people are those whom we are commissioned, if you will, to seek after and to go after, right? And in like similar way, many of them are not busting down the doors of the church or the faith community, but nonetheless, that is those vulnerable populations, those disconnected, marginalized populations. Some of those you may find hard to reach. We have again that similar reach as well, right? And it is a consistent mission and desire to reach that type of population. And so, whereas in community-based organization may sort of have this measure of a slight disconnect, we think the faith community can help bridge that gap in working with community-based organizations to help reach the vulnerable. Again, I just go back to having that shared mission, right, or synergy or likeness of mission and purpose and values that often helps community-based organizations and faith-based organizations be able to work together, because oftentimes we are trying to reach the same population. Well, how can we do it? Why? Because we have a like-mindedness in terms of outreach and goals. We have our sense of core motivation, right, in that regard. And so, as far as the two working together, what's our core motivation between the two? How do we integrate our missions, right? And from a church or faith-based organization, we often, really adopt a holistic model, that integrates the physical, the social, and the spiritual, right, determinants of health. And I don't know if community-based organizations touch all that, but I know that faith-based organizations definitely, seek that sort of holistic approach. And not only that, but with the faith-based, whereas a community-based organization may be sort of limited in its scope, in its geographic boundaries, again, with the faith community, each faith community has an extended reach if they belong to a denomination, right, or a particular local group of churches, right? And so working with one might give you access to many others. But I think when we have a shared core motivation, we have this, that we can understand this is where we integrate a mission and know that we seek a holistic approach, which includes, again, health and physical, social, and spiritual aspects. I think it makes it where the two can work together, even though they have some unique differences.
Great, thanks to both of you. So I know that we touched on this, but so the next questions are for Dr. Thomas and Courtney Christian. And could you tell us a little bit about misunderstandings around engaging social services and faith-based organizations, and any other thoughts around how you build trust, and just commenting on the importance of trust in the process?
Yeah, thank you for that question. I think we've heard from the pastor and from Paris as well that these organizations are really intrinsic parts of the fabric of our lives, right? Um, we are all in community with each other, whether we are a corporation or we're a church or we're community-based org or we're a social services organization. We are all in community with each other. And I think COVID was an illuminating event for everybody when we really realized as a global community, we're all in this, together. And listening to the pastor, reference Tuskegee, one of the things that we did when we first started talking about our clinical trial work with here at Pharma, I remember we had a focus group and we started talking to people about, their lived experiences and historical experience as well. And we asked the question, how much bearing does Tuskegee have on, what you may think about the COVID vaccine coming out and what you may think about clinical trial access. And one of the focus group participants said, "You mean the movie?" And and so we had to have a moment of reset because generationally that word means different things to different people. It has a different meaning for me in Paris and maybe other people on this call, but it may have something else altogether. And so that might be something that contributes to misunderstandings about engaging certain organizations. People come from different perspectives, and to both of their points, trying to figure out how to make those perspectives come together. But I think really one main misunderstanding that I have heard, again, in those focus groups that we had, was that people don't understand enough about their present day issues, their present day lived experiences, right? So even though some of these social justice organizations are there and housed within community, I think there is still a perspective that there is some inability to really understand what their current lived experiences are, what their current healthcare needs are, and where to bridge those gaps and come together. And that issue of trust, continues to come up. I remember another focus group person asked us, "Well, are you coming to help us or are you coming to harm?" And that question to me was so important and has been really at the forefront of all the work that I have done. Am I coming to help or am I coming to harm? And I think I'm coming to help, but what does my help look like if it's not the help that this person needs? And so I think that's also lends itself to another misunderstanding that may, rise up between community organizations and patients thinking about, engaging faith-based and other community-based organizations, and particularly in terms of accessing healthcare. What do you want from me? What's in it for you? Are you doing this out of the goodness of your heart? Is there something in it for you? What's the in it for you? Be upfront with me about what the in it for you may be. And so I think that it's just imperative for industry like ours to just continually show up and do the work. Continually show up and say, we're not coming to hurt. We're not coming to harm. We want to help. We want to be part of a solution. And so that's one thing that we did with our EQB Med clinical trial access program that I mentioned earlier. We said, as Paris alluded to, okay, step one of thinking about what we want to do with clinical trial work, we need to have people from the community at the table. We need to be thinking about how we engage patients from the start. We need to think about who the important community ambassadors are from the start before we start building out this network of a new paradigm of clinical trial access that we want to build. Because, if you don't have the right people in the right places at the beginning, any amount of money that you put into something is not going to turn out for good if you don't have all the right pieces and parts in the first place, and to be able to understand where resources need to be rolled out. And so I just really think those are some real live misunderstandings I think that can arise in a partnership.
And something you said in terms of the what's in it for me, could you comment a little bit more on why industry is investing in partnering with social services and faith-based organizations?
Absolutely. I mean, as I said when I first started, our industry really invests quite a bit into research and development, right? We are chasing the newest and the best, medicines for chronic disease, the newest and the best cures for any range of, chronic conditions, other conditions that may be out there. And so what we really need to make sure to do is to make sure that we have the right patients in the right trials at the right times. And we need to make sure that our medicines are effective for those patient populations, for those indications, for those, chronic diseases and other issues that they may be dealing with. We have to have them in early and often. I have a mentor that says, people from diverse communities should be demanding a seat at the table, not waiting for a seat, but demanding it from the beginning to say, hey, I have a history of triple negative breast cancer in my family, and I need to be at this trial. I have a history of, we just lost a beloved singer, D'Angelo, yesterday to pancreatic cancer. Who knows if he had a history of that in their family. And so what's in it for industry is for our innovative medicines to get to those patients when it's needed. But what's also in it for us too is to really work with those patient advocacy groups that are out there to help understand what their needs are and where we can fill gaps, and really work together for solutions.
Yeah, thank you all for sharing so much. And in the interest of time, I'm going to move on to the next part, which is the how. And also just a reminder for those of you who are listening in that you can submit questions in the platform and we'll be addressing them in a little bit. So the next series of questions, I'll probably first call on Dr. Natalie Razim. So could you talk a little bit about how to work with social services and faith-based organizations on pre-enrollment, preparation of trials, pre-trial engagement, what has worked and what hasn't in your experience?
Yeah, thanks. That's a huge question. And I'm learning as we go. I think the biggest thing was having introductions and connections to the community. I didn't start out having those, so I had to find trusted voices, like many of them, like the pastor that's on the call, that already had established connections, either with my mentors or collaborators. And through those so I went to a lot of different types of community and uh, church-based organizations and activities where I just listened, and I just tried to meet people, and hear about their concerns and what their questions were. Um, I also, just in terms of setting up the clinical trial, Cures Within Reach was really instrumental because they gave me funding at the outset to develop a community advisory board. So through the connections and introductions that I mentioned, I was able to put together a really wonderful community advisory board that represent diverse and predominantly Black men across Chicagoland who meet with me at least quarterly to they helped review my protocol planning. I discussed the source of my clinical trial agent with them. They reviewed my survey questions, and I plan to review data with them on at updated bases prior to learning how they think it would be best to disseminate those results to the community and in what forum. One of the most important pieces I learned is I'm an oncologist, so I usually take care of patients who already have cancer. But in order to be diagnosed with cancer, similar to what's been touched on, you have to first seek care. And that's what I learned from the men on my community advisory board is we really need to first get these men to seek care. And that comes from, that, so even though I'm focusing a lot on the treatment of prostate cancer, the first thing is that I need to make sure that these patients get screened, that they get to the doctor. So a lot of the events that I'm planning with my community advisory board aren't my clinical trials specific. They're more about prostate cancer education and screening in general. And that's a direction I didn't think that I was going to go, but I'm really enjoying.
Thanks. And Dr. Amarim, do you have any comments to share, especially as it may relate to how to find and identify organizations, how to initially approach them about a future trial?
Yes, absolutely. I think at UCSF, we are lucky that we have within the university a group of people that helps you actually find connections with the community. So I think that's something I recommend to folks to actually ask around because you may have something like that in your program, your university, in your school that you may not be aware of. And I think that was helpful for us to have an initial understanding about people in the community and how they were, what kind of questions people would have. But the folks that were identified were actually, on my study specifically, were not the specific group of people I was trying to engage, which in my case were people who were at risk for overdose from drugs. And I had to actually reach out to other social services, to faith-based organizations to understand what people were facing. And then that really opened up a completely different understanding about the study, actually. And because an emergency intervention, right, your heart stops, you have to get resuscitated and all that, we had to really listen how was the experiences of people who were unhoused and in a vulnerable population, their interactions with the emergency medicine services, which go way beyond of having a cardiac arrest, but all the other things that happen. And people were actually very hesitant and had a lot of different experiences that were not necessarily the best experiences. So they were very hesitant about how to engage about something like that. And I learned a lot about what we think is the right intervention or the right approach actually can be completely different about what people really think is the most important or how to start. So it was really an eye-opening experiences. Again, reaching out to my own university, but also go ask other people that were doing research with vulnerable populations. Oh, hey, who did you talk to? And for example, I'm doing work with people who use drugs, so I reached out to the SF AIDS Foundation. So there are different types of foundations who maybe they're not the people who would be able to do the community engagement directly, but they told me, hey, I know this and this person. Why don't you talk to her? So there's a lot of like, I know someone that you should talk to. I know someone that you should talk to. And you really need to put in the work to try to make all those connections. So this is just to say that it's often not as straightforward, right? You really need to go there and try to find who to connect to. And it really changed completely how we were thinking about the intervention and how to approach people, how to do education, and made us rethink how we were planning all those activities. And the Curious Within Reach group also had courses and workshops that were very useful to try to probe those questions and try to think on who to talk to. So I think that was very useful to us.
Yeah, thank you so much. And I know we are getting close to time for the audience Q&A. There's a couple of important themes that I would like to get your thoughts on before we move to that. And one of them has to do with post-trial dissemination. So anyone that would prefer to chime in, how would you share results with the community? And thinking about the community perspective, what is it that they want to hear about the trial's results? Courtney, would you like to? Oh.
Yeah, I can get started here. One of the things that I thought about here, as you're asking that question, is something that comes to mind that we say here is you can't fix what you don't measure, and we have thought about it in the frame of the learning phase of our project of what are we telling, what our 4 M's are: our message, the messenger, the moment, and the media, the how. How are we showing the results of the trials that we are undergoing right now? And so one thing that we have done is, again, utilized our community ambassadors, our pastors. They have newsletters, they have infographics about the trial sites in their areas and the hubs that we've set up. They've done PSAs, voice recorded PSAs, to say, here's the trial, or at the end of the trial to say, here's what we found. And then they've curated sort of, listservs to direct some of the information out to some of the folks who have participated, and to also say, here, see, this was done safely. This was done within with informed consent. This was done under an IRB. This is how you might think about participating in the future.
Yeah, thanks for sharing that information. And Pastor Fields, was there something you wanted to share on this topic before we open it up to the audience?
Yeah, sure. Real quickly, with the Live Faith Network, one of the things we found, and I really want to share a couple of things, just real quickly. One, of course, when we talk about post-trial dissemination, engagement, things of that nature, emphasize, of course, throughout as much as possible, as as part of ethics of research, confidentiality and privacy, right? That's a big issue and a big concern. People want to make sure that what way I participated, that it will not be misused or be used in a way in which I don't agree to. Of course, as clinicians, I'm sure you all know that how important that is, and I'll say it's very important within the African American community and the faith community in which I work in. Right, having that assurance, and sort of 3 parts. I'm gonna just put it this way: get it, share it, and then tell me how you're gonna use it. Sometimes, just how you're going to use it. People just want to know that, hey, this will not be used for something I don't agree with. And of course, a lot of times with just research ethics, people got to know what's happening up front and all of that. It may just need that reminder in the middle, reminder in the end, so you get the information, get that, go through that, maintain that contact, build that relationship, build that trust, and then share it with them. One of the things we did at Live Faith Network when we had thousands of participants in our blood pressure screening. Of course, they got their own information. We were very clear, right, in Work with Rush Hospital, how this information would be used, so that the pastor and the leaders knew what was the intent of it, and that how it will be used for further intervention working toward good health for that same population. In other words, it wasn't going to just be used and then be shipped off to other, which is good, but shipped off to another part of the country, and that community is just left high and dry. And so get it, share it, and be clear how you're going to use it.
Yeah, thanks for that advice. And now I'm gonna ask a few questions coming from the audience. One of them is, how does community engagement change with pediatric trials? Is there anyone that wants to unmute and chime in on that question?
I feel like I need a little bit more information to that question. I know it was probably in the chat. I just feel like in terms of pediatric trials.
I guess if if the trial is dealing with someone's children, how would community engagement or engaging with faith-based organizations and social services change if the individuals in the trials are children? Or would it change?
Yeah, I think it does change based on the social sector that you're looking for. So some of us, if I specifically speak to my social sector, I only serve adults over the age of 18, but I know partner organizations that do focus on children. So if you have trials that are pediatric focused, those would be the most appropriate individuals to be able to engage in that way, because they know that population have built up trust in their own way. So social sector, we reach so many realms. I don't think we all fit in like a one size fits all definition. And so there's so many of us that do these direct things, and even some outside of the healthcare realm that are really interested and do work with children that would be happy to help in this way to be able to further their longevity.
Another one of the questions is centers around funding. So the question is how to fund this effort. How much do social services and faith-based organizations want to get paid? How does it work in practice? Either of you like to share any thoughts around that?
Yeah, I can real quick.
Sorry.
Go ahead, Dr. Paris. No, please go ahead.
I was just going to say, I think that varies per organization, but I tell people it's not just the $10,000 incentive. For example, if someone has a study and they want us to do the recruitment for that study, that takes our time from our CHWs. So our ability to use and pay our staff to use that time towards your study should be appropriately compensated. And that's what I encourage my academic partners to look at when they're budgeting out for that. But then also take into consideration, which everyone doesn't, is that there's administrative fees attached to that. And I think a lot of times they're like, oh, we're paying for the CHWs, but for us to manage our side of the grant and ensure that we're ethically responsible, it is important that we also have those administrative fees covered as well.
And I would say really what oftentimes is not considered, consider those same things for the faith community as well. What we found with the Live Faith Network, is that consider those administrative costs for that church, right? The same thing in terms of having lights on, utilize facility, written rooms, things of that nature. Having stipend for participants. We found that helped, right? We always have a site coordinator, to help, bring about participants and recruit participants. We paid stipend to a site coordinator, right? Who is in that community, part of the church family, part of the faith community, who knows people, knows the ins and outs and nuances, and they become the extension of the clinician or the project who can really have hands and thumbs on participants, and it can help with that communication on all levels. And we found success in certain phases where the funding was available, when there was a stipend for participation, right? And maybe it's in certain phases. Those things were incentives that help. And I just want to encourage you when it comes to the faith community, because there are many who think when it comes to the church faith community, y'all should be doing it free, giving it free. Well, they have overhead costs just like a community-based organization, just like anyone else, and have staffing issues and needs. Plus, they have someone who can help be that extended reach to help you recruit participants.
Thank you both so much for sharing that insight. We have a question. They said, please repeat the 4 M's that Courtney mentions.
Okay, the 4 M's that I mentioned were message, messenger, the moment, and the media. So what is the message that you want to convey? Who's the right person to tell the message? And this was in regards to sort of, results from trials. Who's the right person to tell that message? Is there a particular moment that's right for sharing that? And then, the how, what kind of media do you use to share it?
Yeah, thank you so much. Another question, and I think you touched on this, Pastor Fields, around ethical issues. So the question is, are social services and faith-based organizations aware of ethical issues, IRB's reporting, and what learnings can be shared? Any other thoughts that you would like to share on that?
I'll quickly share from the faith community. No, I had to be. Even though I started on the pilot with AFN, I had to be educated along those things as well. And once I became educated on all of that, the ethics of research, IRBs, and all of that, it helped me in terms of as I interact and engage my congregation. So, come with that information. I think that'll help because they have a full understanding of what they're getting into, as well as you're empowering that community want to work with you, empowering its leader or their leaders so that you can effectively move forward with your initiative.
I would just interject too. One of the things that we have found effective in what we've been doing is we have actually conducted sort of trainings with all of our faith-based leaders. So we take them through a thorough 4-hour training of what is a clinical trial, what is it for, what are the phases of a clinical trial, when does informed consent kick in, when do IRB issues pop in. Here's what the regulatory process looks like. Here's what it looks like to fund your average clinical trial. Here's where all the pieces of the budgetary pie go to. And so it really just helps us help them have a really strong sort of foundation in clinical research and be able to tell their communities a little bit more about, what's happening.
Does anyone else want to chime in on that question before we move on? Yeah. All right. So the next question is, what is the impact of decentralized trials and trials in rural communities on engagement with, or in community engagement? Yeah.
When they're asking about what the impact is, are they asking, should it be done? I mean, I think some of the interesting things with decentralized trials, and maybe some of the doctors could talk about this a little bit, is the opportunity to use technology to monitor people while they're on the trials, right? So they're not coming to one space to do the trials, but they may be, sort of dispersed. What kind of technology is needed for that? I think in one way it could be great because that could expand access. But when you're thinking about basically that's telehealth, you have to think about the digital divide and where people might have access to technology. And the same thing for trials in rural communities. Do people have to travel long distances to get to the trial? What does transportation look like? And those sorts of things. And so, on one hand, a decentralized clinical trial in a rural community might be great. You might access more people, but do those folks in the area have access to the technology needed? So I think there are pluses and minuses to all the things that are coming. And I think even with the introduction of AI is in everything now. How does that also portend to use in clinical trials?
And if I can add, because with the Alive Faith Network, one of our programs we have is Keep It Moving, and which was one where there's self-guided, in other words, sort of an in-person. In other words, that's an example, at least for us, of a decentralized health initiative, if you will. And I think there are a lot of advantages to it, particularly when you have some. I'll use African American men, for example. many times there are certain segments among African American men who is just hard. And I think Dr. Paris or someone mentioned it earlier, right? Uh, their hospital visit or their practitioner is the emergency room, right? In other words, they only go in a time of emergency, right? Many people, and not just African Americans, but may have a phobia toward, coming to the traditional institution. So when you're able to, and we found like running screenings and things, in churches, they've been rather successful, and maybe it's because it's away from that traditionalized institution, big hospital like Rush Hospital, and therefore, again, because it's in a trusted space and place that is, reaching out in terms of health and have its information, things of that nature. Maybe you get more participation in addition to what was said before about the use of technology, if things are home visits, things of that nature. So there's a lot of advantages, I think, to it. And we found with the Live Faith Network that it's worked because most of our initiative has taken place outside of traditional medical institutions.
Well, thank you all so much. We have come up on time, and so we're now ready for your closing thoughts. So if each of you could share one or two key takeaways that you would like everyone to leave with. We will start with Pastor Fields.
Sure. I would say to all the clinicians who are watching, first of all, I really appreciate your interest and hopefully that you will really be willing to do the work. If I may use the term, have an advanced team, right? That really would do the advanced work or have advanced boots on the ground in terms of engaging the faith community, particularly its leaders and its key influencers, right? Which is so key. If you don't get them, and you all probably know that if you don't get them, you're not likely to get many of the congregation or their followers. So you really have to engage them in a way that's compelling, because we as pastors understand the leverage we have, and we don't want to burn our trust, right, by engaging in something that will bring them harm, and then it's on our hands. You get what I'm saying? So, do that work, right? Do that advanced teamwork. The faith community has so much to offer. It's a trusted vehicle, already has an infant structure where you can have workshops and groups and small groups and all kind of things that are happening right there that happens on a weekly and a regular basis that can be very valuable for your research and your health initiatives. But do the advanced work and engage them and seek to make it human. And not just an object of research. Let it be a relationship, right? It's better when we know it's a relationship that you really care about the issue, the health disparity, and you really want to see something, work for the community and for the people. And so that would be my closing words.
Thank you so much. Next, Dr. Thomas.
Yeah, so I think, we are all so interested in partnership and collaboration. And I think at the end of the day, we all have the same goals. It's really about educating the community and not just being able to reach the community, but helping the community understand how participating in your clinical trials ultimately helps them. And so I think it is beneficial for both parties to be on the same page and then to include, the social sectors and faith-based organizations from step one. How can we help create a design of a study that is really, it's ethical, but it is also reaching our target population and ensuring that ultimately people's lives are saved.
Next, Dr. Razine.
I think the biggest thing is to keep an open mind and try to keep everything as a bidirectional conversation and to keep learning and growing and evolving. The original design or the original way that you planned to go about something, it may need to be changed, and you need to have flexibility with that, and it'll probably be better if it was informed by the participants who you actually want to help.
Dr. Emery.
Yeah, I think what was brought up, this long-term view, I think it's really important. When you're trying to write a grant and then you're going to try to come up with a partnership, that's really not how it should be working. I think we need to think about if we're going to tackle a problem, going to be doing that for a while. So you need to start that early. But I think you're going to have new ideas. As I just mentioned from our experience, it completely changed how we thought we were going to engage people in terms of interventions and all that. So if you're not, it's an opportunity loss if you don't do that. And I think the other piece of advice is just to trust, word of mouth is really important. And if you reach one partner, ask them who else you think would be interested in, and trying to be as diverse in the type of group that you're engaging with. I think that's really, really important. It's not because you found one community partner that you should stop there. And I think there's a lot of cross pollination. There's a lot of efforts that can be done in multiple places at the same time. So I think approaching as a network, I think it's really important.
And last but not least, Courtney Christian.
Sure. I have a mentor that shared with me this saying that I think is appropriate, and it is that health is a crown worn by the healthy, but only seen by the infirm. And so I think that's something to keep, ahead of us. We have to respect community, respect their feelings, respect their wishes, while ensuring that we can meet, critical need where we can. And I think the main goal that all of us here, I think, have shared is that we just want to really empower patients to be able to reach their optimal health. And we just want to be in partnership with each other to make that happen.
Yeah, thank you all so, so much for all of the insight you have shared today. It's really been a great conversation. And I'll pass it off to Barbara.
Wonderful. Thank you so much, Tammy, for moderating such an exciting, interesting, fascinating session. Thank you again to all of our speakers. And I was furiously writing. There's so many key takeaways that I wrote down that hopefully a lot of the attendees can take and utilize in their clinical trials, both current as well as, more importantly, all the clinical trials in the future. Thank you all for joining us today. Thank you to Burroughs Wellcome Fund for being our lead sponsor for this type of community-based education. And thank you to our other partners who are funding the community-based education alongside of our clinical trials, in addition to Burroughs Wellcome Fund. We're grateful for all of your time today. Thank you so much. Have a wonderful rest of your day.